Welcome, everyone. My name is David Paré, and I'm the Global Director for the Connected Care portfolio at Daedalus. And today I'll be talking about Connected Care and the role of the active patients as part of their care. Um, in the past, we focused a lot on putting that patient at the center of their care and doing care to them. And now we realize in the past 5, 10, 15 years that that doesn't quite work. The patient needs to be active and make their own decisions and change their own behaviors to get the outcome that they actually hope. So today I'll be going through a few international case studies from our customers around the world, giving you a few insights and lessons learned from how they've done it, how it works, what doesn't work, and hopefully that's helpful for you for your own organization. Let's get into it. So first case study is Dartmouth-Hitchcock, which is a medical center hospital in New Hampshire in the United States, and they focus on international research on population health management. So I know what you may be thinking, the US has a very particular healthcare system, which is very different than socialized healthcare and other healthcare systems around the world. That being said, the approach they took in this particular instance is very much replicable, and it's been done elsewhere in different variable models of healthcare around the world. So I think it's very beneficial and will apply to your own context as well, maybe with some adaptations. So let's bear with me for this presentation, please. All right, so Dr. James Weinstein was the actual CEO of Dartmouth-Hitchcock a little while ago, and like many of us, he figured out that we realized that the healthcare system is somewhat broken and fragmented. But wanted to do something about it. So he decided to create this. He called it Innovation Group, and he gave him a bit of a tagline, like put us out of business, meaning let's focus on patients getting better so they don't need to come to the hospital. It was just to show how far the thinking went with that particular group. So he started by building a multidisciplinary team and made out of people outside of healthcare. So entertainment, hospitality, automobile, mainly people who were really good at customer service and industry actually really good with that, and how we can apply this customer approach led with healthcare. Really staying away as much as he could from all the major vendor of healthcare systems today, particularly in the US, to not get that legacy thinking. And of course, a set of really great clinical champions, so nurses and doctors and so on, to help kind of shape this up in a way that makes sense. So the good news is, in their organization, they actually can tap into 30 years of patient data. There's over 30 million data I've analyzed and a whole lot of research based on population health. So they had that at their disposition to do something. And the whole of that was to identify the social determinants of health that were impacting most their chronic diseases. So things like diabetes and COPD and hypertension and so on. So whilst they were doing the study, they realized that the three major factors that had the most impact, not just them, but the most impact on the ability of a patient to manage their own health and the chronic management side, was transport, food, and education, meaning that do I have the knowledge to do what I need to do to take care of myself? Can I, if I have to go to school, is there any good school near my house? Can I actually travel there? Is there a bus? Do I have a car? Do I know how to drive? Do I have access to good food? Is the good food accessible? Do I understand how to use the food, and do I know how to cook it? So all these three elements together have the most impact on helping the patients take care of their own health and chronic disease. So they did a few tries with surveys to try to get and trying to capture what we called behaviors and elements of their life, but it was pretty disappointing, which is not to be, not surprising at all. 30 to 40% participation, and the data they gathered was less than ideal. So they needed to find another way. So they looked at the apps, kind of what's in the market, and there's a lot of them. Unfortunately, many of those apps really focus on a single specific condition, like diabetes type 2, or hypertension, or mental health. Not really a holistic view of that patient. And what we want to do here is really look at the patient as a whole and what we can do to take care of that patient beyond the walls of the hospital, including, things like where you come from, your parents, your environment, the quality of the air, the quality of the water, so on and so forth, and all of that. And they really were trying to focus on how they could apply the research that they've done in this space in the past 30 years to actually take care of those patients as a whole. And of course, like many of us, we've seen all these IoT devices everywhere, but how could they apply that to the research and actually make that meaningful? And how do you capture lifestyle data, which is quite difficult? because when you ask people to do it, they don't necessarily do it because they don't want to. So we need to find different approaches to be able to do that. So one of the challenges they had is a cohort of 4,000 patients. So they started with a small cohort, about 100 patients, did a small trials with a small app and a few devices, and worked really well in about a couple months. And now they gave themselves about 12 months. They said, all right, let's see how we can scale this model to 4,000 patients. The challenge they had is that typically, and you guys can argue with me on this one, but typically the ratio of a nurse patient is about 1 to 20 to 40. So one nurse for 20 or 40 patients. It could be, if you want to push it, one nurse for 100 patients, that's fine too. But it's still not enough to scale to millions of populations. So how do you make a model that allows us to scale more without the needs of more healthcare professionals? So obviously you need some kind of digital tool. And of course here, this is our shameless plug, which is about providing the way we look at it is having a software as a service, digital platform, digital front door that sits on your existing landscape of applications, your EMR, your lab systems, your radiology systems, your GP, community health, social care, and all of that. And then providing that experience to take care of those patients, providing the engagement with the clinicians, the patients, caring for the patients, all the remote patient panel monitoring tools, the booking, the scheduling, and all of that underpinning by all the plumbing required to integrate all these systems with the new platform. So this is what we did with this particular customer. You also need an app and a bunch of devices in this particular case. So here we have a very cool mobile app that we built, and 4 devices: an inhaler, a Bluetooth weight scale, a wristband, and a blood pressure cuff. All of that Bluetooth connected, and the idea was to give us a way to remotely monitor the patients in terms of vitals and some of their lifestyle choices, as well as prompt them using the app. So now we've done that, how do you monitor and manage 4,000 patients without having to hire an army of nurses? So what they did, after playing around for like a month or so, a few weeks, they decided to go with a model of care coordination control center, and they had this concept of pods. And each pod would be constituted of 1 nurse or registered nurse and 2 health navigators. So health navigators are customer service people who know nothing about healthcare, but they're really good at customer service. They understand customers and how to deal with those people and understand how the behaviors are. So they realized that with this particular model, 1 nurse in the pod and 1 nurse in each pod and 2 health navigators per pod, but 3 people could cater for about 2,000 people. So now we're starting to scale in a way that makes a whole lot of sense. And we actually, since then, they've actually increased that model for 1 nurse to about 5,000 people. And now you can start to scale a lot more easily. So now you have all the tools, you have the devices, you have the app, and you have the knowledge and the centers. How do you actually engage with the patient? So how do you create this intimacy? There's a whole raft of reasons way you can do that. And the way they've done it is by understanding, for instance, that Mrs. White is 85 and she's at home and she doesn't like to be bothered on a Monday morning because that's when her son comes. And she only wants to be communicated through text messages because that's what she likes. And don't bother her on Thursdays and Wednesday night because that's when she walks her shows. So all these information were captured inside the platform, so we can actually understand better how to deal with Mrs. White. So and so on and so forth. There's a whole raft more into it here. And as an example, one of the things they've done towards the finally one of the earlier seasons of Game of Thrones was to let's do a test, right? So they knew that most of their customers, patients, preferred text messages as a way of communication. So they had to target all the hypertension cohorts, which was about half of them, and send them a text message on the night of the finale. Say, hey, tonight's a great finale. By the way, don't forget to take your meds so you don't have any issues and have a lot of fun. This creates, again, this link of I understand you, I know who you are, a personalized kind of approach, and it worked really, really well, right? So there was no issues afterwards, and it worked really well. Another element that's important to consider is the role of mental health in managing chronic conditions. So you see, if you have mental health issues, it's even harder for you to manage your own diabetes or congestive heart failures or COPD or so on, right? So, and here's an example of how a system like this can work. So, and this is a real example that I was told by this customer. So Mary stayed home for multiple days, and Mary is usually pretty active. So through the department noticed that Mary hasn't been kind of walking, doing her steps for the past few days, and didn't take her meds. And something was fishy. So instead of calling her and say, "What's happening, Mary? Why are you going out?" and blah blah blah. So the approach they took is, well, once the system notified the health navigator there was an issue, they called Mary and said, "How's it going? We've noticed that you're not going out too well." And they realized that Mary actually felt disoriented, and they actually diagnosed her with some anxiety and stress and depression. So they realized that they were able to actually cater for her, and she was really pleased. And because of that, Mary didn't have any issues. And they ended up at the hospital. They were able to take care of her remotely in the comfort of her home. So again, this kind of model where we can remotely assess patients and act as soon as something happens or before it happens is a model where there's less people coming out of the hospital. And these are real examples of stuff that actually happens. So how did it go? So after 12 months, 95% of customer satisfaction, which is unheard of in healthcare and in other industry as well. They had a 22% reduction in emergency costs for the hospital, and they had 36% reduction in total cost of care for the hospital for each patient, which is quite impressive. Because you would think that for a private healthcare organization in the US, who actually essentially is there to make money, why would they do something like that? So I did ask the question to the CFO and say, the chief financial officer, and say, "Hey, why are you guys doing this? And isn't it against the grain of the organization?" He said, "No, actually what happens is that we can, now that the easy kind of assessments and activities are handled by the Care Coordination Center group, then I can focus my staff on highly specialized activities, and these are more lucrative. So it's more benefit because we can do more of these high, specific surgeries and so on for more complex patients, so we can get more of them. And at the same time, we're also, of course, the revenue increases. So it's a win-win for everyone." So I was quite surprised, and that's what I mean here by this model could be effective in a socialized healthcare environment or in a privatized healthcare environment. It could be Europe, and we've seen some of these models popping out around the world, and I'll talk about some of that in a few minutes. All right, so that was one customer. So it's a really good kind of in-depth view of what they did. Here's two more examples before we wrap up. So another one is a private health organization called Care Complete in Australia. And what they've done is actually create a program to deal with some of these issues and provide these services to patients that are insured across everywhere. And they realized that there was a lot of needs, things like coordination of care, post-hospital support. They started with chemotherapy and rehab in the home, and now with coronavirus and meds management and so on. But to have a whole bunch of these services, now they actually provide these services, and they're hired by all the healthcare, either public system, private systems, and even health insurances around the country, because these actually are effective and less costly for everyone. So a really good example of a model that works today, and they're using it at the similar platform we've deployed at this other customer in the US, which is our ConnectedCare Cloud. South Australia, again, now we're moving away from the private and into the public health system. So the new chief executive officer came in and the health government and created this model called My Home Hospital. And the idea of that was, again, how do we make sure how we can cater for our population outside the hospital? So they started with a smaller geography and started to provide these services to mostly the elderly people and some of the chronic management people. And they focused on some specific DRGs or activities around, as you see, heart failure and post-operative care and supportive care, insert care, and so on and so forth, and with a few restrictions on how you can onboard these patients. And now it was so successful after 6 to 12 months that now they're expanding the number of DRGs as well as the number of the size of geography into other town and sections of the state. So again, a model that very similar and works really well, but outside the walls of the hospital. And this is done by public health government in a socialized healthcare environment, which is Australia, which is very similar to the UK or France or Europe or Canada. So I hope that was useful. These are just a few examples. Of course, we have a lot more. I hope you learned something. There was a few insights that were valuable for you. If you have any questions, please feel free to reach out. I'm sure the team will be there to answer all your questions, and enjoy the rest of your day. Bye.